This video continues Chapter 15 of OEC 6, looking at cardiovascular emergencies. In this video, we want to focus on the assessment of a cardiovascular emergent patient by demonstrating how to assess and treat that patient and to look specifically at signs and symptoms of these cardiovascular disorders. Some key terms that we'll encounter: angina pectoris, aortic aneurysms, arrhythmia, asystole, atherosclerosis, AED, congestive heart failure, coronary artery disease, ischemia, pericarditis, pulmonary edema, sudden cardiac arrest, ventricular fibrillation, and another type of arrhythmia, ventricular tachycardia. Let's begin with cardiovascular emergencies. Most causes of cardiovascular system failure can be tied to cardiovascular disease. Some of these could be high blood pressure, congestive heart failure, AMIs, or stroke. A heart attack, also known as an acute, meaning rapid onset, myocardial infarction, is common in individuals 40 to 70 years of age and remains a significant problem in the elderly. If we have an AMI, this may progress to a sudden cardiac arrest. Now, some of the causes of cardiovascular disease are coronary artery disease, a potential blockage or narrowing of the coronary arteries, and atherosclerosis, when plaques form within the walls of arteries due to cholesterol or lipids being elevated in the blood. An additional type of cardiovascular emergency is congestive heart failure. The heart cannot adequately pump blood to the body tissues. What happens then is blood backs up in the major blood vessels leading to the heart and certain organs, and eventually both sides, or at least one side of the heart, can fail. Now, think about our anatomy. Whether this failure of pumping blood occurs on the right side or the left side of the heart manifests differently. Right-sided CHF, that is, on the right side of the patient's heart, where we're bringing returning blood into the atrium and then pumping it to the to the lungs, is going to cause leakage of fluid backed up in those veins into the extremities, and we a lot of times will see swelling in the feet and ankles as a result. Left-sided CHF, failure of the pump on the left side to move blood out into the body, is going to cause a backup at the top of the left atrium of the heart, where blood has been returning from the lungs. Consequently, any backup through the left side of the heart, left atria and left ventricle, is going to lead to pulmonary edema. We're going to end up with fluid building up in the lungs because we can't adequately exit the blood from the left side of the heart and pump it to the body. Pulmonary edema, this accumulation of fluid in the lungs, in addition to congestive heart failure specifically on the left side, may have other causes such as untreated hypertension or high blood pressure, and perhaps even direct trauma to the lung tissue. We really want to think about this inability of the left ventricle to pump blood effectively, however, as a cause for pulmonary edema. As blood backs up into the lungs, we'll get an increase in the fluid pressure, and then correspondingly, fluid seeps from our pulmonary capillaries. Think of it this way as part of the cardiovascular system into the alveoli, part of the respiratory system, fluid building up in where that gas exchange should be occurring. Well, what will that lead to? It will lead to hypoxia and associated respiratory distress. The respiratory centers within the brain signal the body to breathe faster in an effort to combat that hypoxia. We may see in extreme or advanced cases frothy blood-tinged fluid to be coughed up due to the fluid backup in the alveoli. Another cause, discussed later with altitude injuries, Another cause of pulmonary edema could be an altitude injury. Angina pectoris is chest pain or discomfort caused by ischemia, which is essentially a blockage, therefore leading to lack of oxygen, getting specifically to the heart muscle. This will manifest itself as chest discomfort. And a myocardial infarction, blockage of one of those coronary arteries, can lead to specific death in that heart muscle. Now, blood clot is one common source of the blockage, and this can be treated in a cardiac catheter lab in the hospital because perhaps we have a plaque building up inside the coronary artery that has become dislodged and that eventually provides the blockage. Another possibility is just growth of plaques that over time, if this was the vessel, will start to constrict it and start to constrict it even more until they eventually prevent blood flow. Heart tissue supplied by an obstructed artery becomes starved for oxygen and eventually begins to die. This is called an infarct. Now, in addition to that, we need to consider the possibility of a cardiac arrhythmia. And if we take this apart, here's this prefix a or an, which in medical terms means without. So we have a heart without rhythm. It is irregular. And so those arrhythmias can be caused by blockage of the electrical pathway or an abnormal electrical signal. Sudden life-threatening arrhythmias can be caused by the ischemia we've described before. The effects of some of these arrhythmias are to slow the heart to below 60 beats per minute, bradycardia, or to speed it up above 100, tachycardia, or to alter the regularity of the rhythm, or even lead to a sudden cardiac arrest. Not all arrhythmias are immediately life-threatening. Some, in fact, are relatively benign. Some of these chronic arrhythmias may be put on medications that prevent the blood from clotting, so no further ischemia may occur. We think of these as blood thinners. And by slowing the normal clotting process, we can address some of these certain medical conditions. Common blood thinners may include a daily aspirin, warfarin or Coumadin, or Plavix or Pradaxa. We see these as essentially trade names. The generic names are listed here. Now, if enough heart muscle is suddenly and severely damaged, the patient may go into a form of cardiogenic shock. Our shock is always due to a problem with pump, pipes, or fluid. And in the case of some of those pipes, for example, it may be something external, such as anaphylaxis causing it. A pump problem is specifically right here, cardiogenic shock. The heart is inadequately pumping blood, and that may lead to a sudden cardiac arrest. Now, one of the causes could be ventricular fibrillation. What we have is cardiac muscle cells not working in a coordinated fashion, which leads to ineffective contractions of the ventricles. Think of it this way. If I have a cardiac muscle cell adjacent to another one, and they both were to contract at the same time, we would have an effective pumping as those cells shorten and then relax and elongate and return. But what if we had the additional situation where perhaps one cell contracts while the other one doesn't, and then that cell relaxes while the next one does? This is an arrhythmia. They're not working together, and we end up with fibrillation. We end up with ineffective contractions. Those cardiac muscle cells need to work in conjunction. If they don't, and we get ineffective pumping, we get cardiac arrest. Ventricular tachycardia is a rapid, regular contraction of the ventricles, still leading to ineffective blood flow because we don't allow for the atrium to completely fill that larger ventricular chamber and effectively pump blood to body tissues. We also have asystole without pumping. the abrupt cessation of all cardiac electrical activity. In these three cases, CPR is critical for patient survival, along with use of an AED to restore an effective heart rhythm. Now, we may also encounter inflammation of the sac around the heart. The sac around the heart is the pericardium. The prefix peri means around, and itis is that medical suffix that means inflammation. Several causes of that could be myocardial infarction or infection. A pericardial tamponade is fluid building up within the pericardial sac that could occur from trauma. We've seen several indications of emergencies, either respiratory or cardiovascularly, where we understand critical organs are encased in essentially a sac, such as a pneumothorax in which air gets between the pleura and the lung. In this case, we may have fluid or blood in between the sac surrounding the heart and the heart itself. That pressure on the heart, due to the buildup of fluid, will restrict its ability to pump. Another critical emergency is an aortic aneurysm. The aorta, that important vessel that leaves the heart from the left ventricle and carrying blood to distal tissues, can form a bubble, very similar to what you would see on an overinflated bicycle inner tube. Anywhere along the length of the aorta, that bubble is what we call an aneurysm. Now, if that aneurysm was to burst, the patient would bleed to death within minutes, because essentially we have the largest vessel in their entire body opening up. Aortic dissection is a traumatic injury where we get the inner wall tearing away from the outer wall due to high pressure within the aorta and causing it to rupture as a result. Now, the symptoms for this will be that tearing sensation between the shoulder blades, and it may be tough to differentiate from an acute myocardial infarction. Again, traumatically, an abrupt stop could cause tearing of that aorta and aortic dissection. Rupture and rapid death could result. We may encounter this traumatically if we see a skier hit a tree at fast speed.